Okay, Bismillah ar-Rahman ar-Rahim. This is Dr.Wael Ghabban here in King Fahd Military Complex in Dhahran, Saudi Arabia. This is a live stream from Dentiscope. Thank them for inviting me to give you this live stream on restorative management of endodontically treated. So we're talking about, this is the subject, and hopefully it will be an interesting subject to you. And if you have questions, we'll try to answer them in the end, inshallah. So again, restorative management of endodontically treated teeth, and this is by Dentiscope with Dr. Wael. Okay, Bismillah. First of all, greetings from King Fahd Military Complex here in Dhahran. Here we have a full dental center with all the specialties, and we have a great group. You're welcome to come and visit us here at any time. So into the subject, why restoring a vital tooth is so different from a non-vital one. First, let's get you some statistics on what's happening. In a survey by the American Dental Association, there were 15 million root canals annually in the US. That's 41,000 root canals each day. Compare that number with the amount of implants annually, which is 5 million. So it's like 3 times as much. So it's a big issue. It's a big market, and it's a good market in saving teeth. So it's a good job to save teeth as much as we can when we can. Again, so why is it an issue? What's the difference between a vital tooth and restoring a vital tooth and endodontically treated tooth? First, we have loss of tooth structure, which is an issue, altered physical properties, and altered aesthetic properties as well. When you do a root canal, the axis itself, the endodontic axis, destroys the structural integrity of the tooth. This causes greater flexion when the tooth functions. So the main thing is not, as was said before by previous authors, that it's dehydration, it's more stiffer. Actually, it's more than that. It's because the structural integrity is damaged, the central portion of the tooth. So like I said, the amount of central tooth structure is in direct relationship with the amount of deformation under loading. The altered physical properties that also happens is the neurosensory feedback. I don't know why this is not so clear. Okay, maybe this is better. Okay, this is better. When you have when root canal is done, sometimes the neurosensory feedback is impaired. This decreases the protection of the tooth. That means when you bite, sometimes you tend to bite a little bit more because a loss of the feedback mechanism. So now we go to the type of restorations. Basically, the type of restorations we have are build-up core material alone, which could be a composite, glass ionomer, amalgam, and then we have the post and core material. The post could be a cast post and core. That's one, and the other one is a prefabricated post. Could be a metal, could be a fiber post, and overall the crown in the end. So when you have an endo-treated tooth, the question is, where do we start? Is it restorable? Do I do a post? Do I do a core? Do I have to crown the tooth? How do you make the decision? The decision is not just one decision. You have to think about so many things. It's all in this slide. You have to know first the prosthetic plan. What's the plan you're going to use? Is it an abutment for an FPD? Is it a single crown? Is it an abutment for an RPD? All of this is different. Position of the arch, the tooth in the arch. An anterior tooth receives forces differently from a posterior tooth. The functional requirements. A molar has more functional requirements than an anterior tooth. Also remaining tooth structure. Then we can talk about the length and the width of the post, the type of the post you're going to use, the need for ferrule. But beginning is usually the prosthetic plan, the position of the tooth in the arch, and the requirements of that tooth, the functional requirements of that tooth. So first we go to the prosthetic plan. The prosthetic plan usually is going to be for a crown. It's going to be a single crown, or an abutment for a for a fixed partial denture, or an abutment for a removable partial denture. If there's a cantilever on this tooth, if there's power function in the patient, all this affects the way you plan the case. If you're going to do a core alone, if you're going to do a post, if you're going to do a fiber post or a cast post, or if you're going to do a crown, all this affects what you're going to do. And it significantly increases the risk if we add more to it. A single crown has less risk than an FPD or an abutment for an RPD. And also, if a patient has power function, even a single crown will have a high risk, because you cannot sometimes control this power functional habit. The next thing on the list of what to look for when you're restoring a tooth is the position of the tooth in the arch. When you have an anterior tooth, the forces generally are horizontal, lateral forces. They're not on the long axis of the tooth, so they're really destructive to the tooth because they're not on the long axis of the tooth. Posterior teeth, however, they have a more vertical approach of the force, and therefore they withstand forces more favorably than anterior teeth. So when you decide on doing a post and core, anterior tooth most likely will need a post, and the posterior teeth will less likely need a post. The third factor in deciding on how to restore a tooth or what to restore it with is the functional requirements of the tooth. So if you have a single tooth or multiple teeth and you have loss of periodontium, the crown root ratio is unfavorable, or you have increased tooth wear, these are signs telling you this is not normal. You have to take a different approach. That means you have more functional requirements required by that tooth. A deep vertical overbite or loss of posterior support, like in this case here. In this case, you can see you have the anterior teeth. They're destructed, they have defective restorations, and they need root canal treatment and post and core. But what you see here, what is important in this case here, is the lack of posterior support. So even if you manage to do a good root canal, a good post and core, the loss of posterior support here is not going to be favorable to the anterior teeth. You're going to have so much force on these teeth, you're going to lose, eventually you're going to break them, because there's no even distribution of forces on your teeth. So it's not just about, is this tooth restorable, which is a question I hear every day. It's not about just restorability, it's about maintaining it. How can I maintain this tooth to be restorable the longest possible time to be successful and fulfill the patient needs? So in this case, you need to first fabricate removable partial denture to establish posterior support. Then you go to root canal treatment for the anterior teeth, post and cores, single crowns, and so forth. So managing these cases is not just on a single tooth basis. You have to look at the entire picture, and everything is case dependent. So one case you could do just a single restoration to close the axis and you're done, no need for a crown. The same tooth in another patient, you would need a post and core and a crown. So it's case dependent, depends on the functional requirements, like I said, in each different individual. And add to that, if you have a parafunctional habits, this is going to add so much forces that even the simple restoration could be under extensive load and might fracture. To continue, so here, like in this case, there was no need for a post and core. You just need to do a crown, and that's it. It was already prepared, so that's why you need a crown. But only a restoration would be enough to close the axis, and a single crown, and that would be it. No need for a post and core. So a post is not indicated for every case. It's just dependent on the case, dependent on what you do on the requirements of that case. For example, this case here, a lot of work was done, a nice endo, a nice post and course, good length, single crowns here, maybe a 4-unit bridge. I wouldn't do that maybe, but in general it looks okay. But something was missed. No posterior support. Everything is just here. It's just like a hammering down on those anterior teeth. So when the patient came to me, actually, she came like this. So I went back to the files. I wanted to know what happened, and then I found that this was how it was a year before, and she was like that for a year. And when she came to me, this is how she came. And eventually, the patient wasn't really a good patient to follow up on. She didn't follow up, and she also lost these teeth as well, because no posterior support was provided. So, like I said, it's not just about a single tooth. You have to look at the entire picture when you're dealing with root canal treated teeth. A favorable occlusive design. When you have a favorable prosthesis design, it's actually more important by many authors for the survival of endodontically treated teeth. And it's even more important than the type of post used. Like the case before, if you see this case here, the posts were done very nicely, I think. A good length, single crowns, everything's okay. Until now, this case is okay. Well, we're starting this case. But they need to be redone because you have a defective crowns here and everything, and inflamed gingiva, and here needs to change the crowns and everything. But before doing all this, you need to provide posterior support, because everything you do here is going to fail. Because all the force is just from the first premolar to the first premolar. So this is under extreme force. So it's not going to last long until you start providing a posterior support. Then we can talk about changing the crowns here and redoing all this work again. So you need a favorable occlusive prosthesis design before starting the case and prepping it and temping and all that stuff. Doing all that effort, in the end, it might fail because unfavorable occlusion. The next factor that's important when you're restoring to endodontic treated teeth is the remaining tooth structure. If there was a single factor, if you're gonna depend on just one single factor, which there isn't a single factor, is the number of remaining walls. The less walls you have, the less fracture resistance you have. Simple as that. So the more walls missing, the more force you have on that tooth, and the less success rate actually you're gonna have, even with a post. So when you use a post with less walls, you're gonna have also less success rate than when you're doing a post on a tooth with a little bit more, 2 or more walls. So let's do a decision-making process. We have remaining tooth structure. You want to do a core or you want to do a post. How do you make up your mind? How do you know? Which is addition to what we said before regarding prosthesis design, the occlusal factors, the position of the tooth. Let's just look at the remaining tooth structure. If you analyze this tooth and you go by thirds or fourths, and you have less than 50% of tooth structure, you're gonna need a post. Otherwise, you're gonna fracture, like what happened here. This tooth had a huge amalgam MOD and GI, I think, here. And it came to me with fractured parietal wall. This is the only tooth structure left. So this is less like 1/3 or 1/4 of the tooth structure. And no doubt it fractured. So if you're going to use a build-up core material, composite, I'm not in favor of using amalgam just because it doesn't bond to the tooth structure. You can use amalgam, but be careful because you need to crown as soon as possible because amalgam doesn't bond, and I've seen a lot of cases that they just fracture, especially MOD amalgam on premolars. They just don't work. They fracture if they stay there for a long time without coronal coverage. So like this tooth here, we have an occlusomesial cavity or restoration. There was no need for a post. You have a nice pulp chamber there. So a restoration was done, and it was enough. So there was no need for it. Let's take a look at another case for decision making. When we look at this, all this debris, all this caries, barely enough walls. Of course, you have more than 50% of the tooth loss. You're gonna need a post and core, and definitely, whether it's a cast post and core or a fiber post in a composite core, it's up to your choice. Here, as you can see, we did a fiber post and a composite core in this case. And you can see you have well over 60-70% of the tooth structure lost. But the deciding factor is here what makes it successful: proper occlusal design and good length of the post and a presence of a ferrule, which is very important. We're going to talk about later. Let's get some stats on the long-term statistics of endodontic treated teeth. This is a study recently in 2017. It showed that the survival rate of endodontic teeth with fiber posts was 94%, compared to 76% without a fiber post. And this study was done in 2017 for single unit restorations. So there's a huge difference than when you use a post and when you don't use a post. So it makes a big difference, especially when it, like I said, when it's indicated. We don't put a post for every case, just like I said, when it's indicated. If you look at this chart, and just don't be upset, just a little chart. I just want to show you two things. Here we have no post group, and here the post group. Okay, I just want you to see, and here we have the number of walls remaining. So we have 4 walls, 3 walls remaining, 2 walls, and 1 wall remaining. Just look at the success rate when we compare no post, 66%. When we have 3 coronal walls, imagine we have like an MO only axis. So we have the buccal mesial distal wall or palatal wall. The success without a post is 66.7%. With a post is 94%. This study was done on premolars back in 2012 by Marco Ferrari in Italy. When you look at the second group, when we have less walls, see the percentage goes down. The less walls, the less percentage we have. So when we have 2 walls, we have 52.9%, almost 53%. This is without a post. Success, not survival, success. And we have almost 89% success with a post in a 2-wall cavity, coronal walls, 2 coronal walls. And we have only 1 wall left, like a buccal wall or a palatal wall, with no post. Imagine success is 30%, compared to almost 78% when we use a post. So a post dramatically increases the success of teeth, especially in small teeth like premolars, when you have less walls to deal with. So the less walls, the less success, but you have a better success if you use a post. Now we go to the part. Well, usually a lot of people ask about how long is the post and the width of it, which is actually, this is it's important, but compared to the other things we talk about, we take it in that order. Now we talk about the length and width of the post. Usually recommended by many authors, the length of the post should be 2/3 of the canal, or at least equal to the coronal length of the tooth. So if you have a central incisor, you just like 11 millimeters high, you need to go like 11 meters inside the canal, almost from the orifice area, or to leave at least 5 millimeters of gutta perca for apical seal. And of course, you just need minimal canal preparation. You don't need to over prepare. Just remove the gutta perca as needed only. Leave intact dentine, because the residual dentine you leave, the better prognosis of that tooth you're going to have, and the better resistance to fracture you're going to have. So like again, 2/3 of the length equal the coronal length of the crown, the future crown, and to leave at least 5 millimeters of gutta perca. The length of the post is very important. It's been proven by many studies that when you have a longer root, you have less root fractures. So if you have 2/3 of the post associated with vertical root fracture, because you had really short roots, ending cervical third of the root. Now we're going to talk about the ferrule, which is an important concept. Just block it. Let's talk about here. Okay, the ferrule. The ferrule is it's this area here. Let me show you. Just give me a second. I can't. You're not doing it right. Just give me a second. Okay, sorry, interruption. Managed. So the ferrule is the amount of tooth structure you have below the core. It's this area here. Okay, it's this area here. It's recommended to be about 1.5 to 2 millimeters. And what it does, it resists lateral forces. It gives you the best resistance retention form, and it decreases the incidence of fracture. And like I said, it's recommended to be 1.5 to 2 millimeters. And when you don't have a ferrule, it's recommended to do crown lengthening or ortho extrusion. So, like I said, this is the ferrule, this colored area here. Okay, let me show you something here. This is a case that was done a long time ago, just to show you the importance of a ferrule. Okay, imagine this. This is the canine, a premolar, and the second premolar. And I know you would say, no way, this is restorable. This is a remaining root. Well, we had good length. So what we did crown lengthening. Imagine here. And then we did a cast post and core. Imagine there. And we took it from here to here. So we just saved 3 teeth. And you say, okay, what's the long-term prognosis? Well, the long-term prognosis is pretty good. If you look at the case, this is how it was before. And we did it on both sides, not just one. We did it also on the right side here, the one I showed you just now, and also on the left side. So the left side was also the same thing. And here it is before, and here it is 7 years post-op. So yes, it works. It takes a lot of effort to save teeth, but it's worth it. So this radiograph here is taken 7 years post-op. So yeah, you can save teeth with crown lengthening, good ferrule, proper prosthesis design and occlusal design, and a good patient actually with a good follow-up, which comes to follow-up every time. But sometimes even with all our efforts, we just can't do it. Sometimes extraction of tooth and putting an implant is a better choice because aesthetically you cannot do crown lengthening, or because you just have a short root. You can't do ortho extrusion, and you will have an unfavorable crown root ratio. So sometimes, unfortunately, you have to remove the tooth. So now we come to the part where actually it's more hands-on, or what you really look for, which is just the shape and type of the post. Usually we try in general characteristics of a post to have that conforms to the natural tooth form, preserves the dentine, it's retentive, and it's relatively smooth. So these are the requirements of a post usually. Additional requirements which are really favorable to have if they're aesthetic, clear or white at least, non-rigid, to be flexible, as flexibility as a tooth, because it protects the root from fracture, has superior strength. It's great that if it bonds to dentine, it has light transmission, and another favorable property is to be easily retrieved if failure occurs. So these are additional properties that we wish to have on in a post actually. But by all means, please avoid these active threaded posts. This is what happens. You're just gonna break the tooth in half. So active threaded post, if you want to use a cast post, fiber post, metal post, go ahead, but please do not use active threaded posts. So the armamentarium, usually what we have when we're doing build up or a post and core, you need good isolation. You can use a rubber dam, you can use retraction cores, mouth retractors, whatever is available. And my choice is usually a piezo reamer or a heated instrument. A piezo reamer will give you a nice removal of the gutta perca without the fear of a perforation, as long as using a push in-out motion and with a very low speed with good irrigation. Another tool you can use is the heated instrument, which is a good tool for removing it. I use a taper post. Usually, this is my selection of armamentarium, and adhesive resin cement. Whenever possible, always. I want to have a bonded, homogeneous structure, from the core to the post to the tooth. Because we had issues before in the past that posts do not reinforce endotreated teeth, and it's been said in the last decade that the main occupation, or the main thing you need to use a post for is to retain the core, which is true, but it also reinforces a structurally compromised tooth. It's been said by many authors here that a bonded fiber post will make the root more resistant to fracture, and it may strengthen the root when properly bonded, with proper length, with proper ferrule, and proper occlusal design, of course. Prosthetic occlusal design. So now we go to the techniques. The first is, I'm going to just talk briefly about these, the cast post and core, and fiber post, and the custom fiber post. So the cast post and core has been used for decades. It's the oldest one been used. It has the advantage of strength. It conforms to the canal shape because it's custom made. The only thing about it is it needs 2 appointments, because you need to cast it and come back and cement it, leaving the canal empty, and sometimes that's not a good way. The other thing is unfavorable failure, because it's so retentive and it's so rigid. When it fails, unfortunately, usually it's by root fracture. So you have to extract the tooth, basically. So what you do is use a pattern resin, what we use, and a plastic post, basically. And this is a technique published 2016 by Anatomically, how to simplify doing the post and core using this technique. So what you do is you bring putty and you just immerse a fiber post inside, then you remove it, then you start shaping your plastic post with pattern resin. So you put pattern resin on the plastic post. Here you just remove the plastic post and you use the void here. So you put lubricant and just get rid of the plastic post, no need anymore. Then you bring a plastic post and you add resin and you just dip it inside this void, so it gives you an initial shape. Then you use the powder bead technique and you go to the patient mouth and you customize it to that canal. So this just gives you the initial layer to start, which I thought it's a nice technique. Traditionally, we just put the resin pattern on the plastic post, and you moisten the canal and you lubricate it either with saline or a glycerin base that's easily removed, but don't use Vaseline at all because it's difficult to remove. Then you just put it inside the canal and in and out motion until it sets. Then you have the post, the canal part done. Then you can do the core part. Using the core part, you can use a prefab crown. Cut it to proper length. Then you just put Vaseline inside to lubricate the crown. Fill it with pattern resin. Then just put it on top after you cut this. Put it on top. Then you'll get a nice prep. Then you can prep it, of course, and you'll have your custom-made cast post and core after casting, of course. The next one, which is mostly used because not just because aesthetics and also because it's easy, because it's done in one appointment. which is in a fiber post. It's high aesthetics, non-rigid, therefore protects the tooth from fracture. Meaning is when it fractures, or when it fails, usually it fails in a favorable manner. That means you can still save the tooth, which is good. It bonds to dentine, which is excellent. Lies transmission, like I said before, it's easily retrieved. Basically, you try in the post. You try in the post. This is from a 3M company. You'll find it in their website for Real IX Unisym. You try in the post, adjust it, and you cut it with a burr or with a disc. Don't clip it off with scissors or with a blade. You're gonna ruin the post. So you cut it with a disc or with a high-speed handpiece. After you adjust it, then you clean it with alcohol swab, air dry it. Here, disinfecting or cleaning the canal with saline sodium chloride. Add your post, and here's the important thing: is adding this extension tip here. This is the most important thing here. This extension tip, elongation tip. This virtually will have no bubbles. If you use this tip, you'll have no bubbles. So you attach it, full depth, fill it, then you just pull gently out. Then you put your post. You can tack cure it for a few seconds to remove the excess. Then full cure it for 40 seconds or wait for 5 minutes. And this is the approach for cementing a fiber post. Then you can make your core out of composite. And like I said, you can find this in the 3M website for Real IX Unisym here. And this just shows you how you can do it. Defective restoration, or actual glass ionomer restorations here in all four. Remove it, clean it, and you can see in all the teeth we have a good ferrule, which is the important thing. Plus, like I said before, posterior support, proper occlusal design. I keep saying it a lot of times because this is really what dictates success of your work. Because if you have unfavorable occlusal design, it's just gonna fail. No matter how beautiful you prep it, how beautifully you do the post and core and all that, in the end, if you don't have a proper occlusal design, it's just gonna fail. So this is how it looks like for the fiber post. I mentioned before that when it fails, the difference between a fiber post and a metal post. The fiber post, when it fails, usually it fails at the level of the gingiva. So you can salvage the tooth, which is good. You can still save the tooth if it fractures, the fiber post. The problem with the metal post, it fractures way deep inside. That's the problem. It fractures way deep inside the apical third, middle third of the root. Then you can't save the tooth anymore. You cannot do a post anymore. You just basically you're gonna extract the tooth. So yeah, that's the main difference. Okay, we're good on time. Anatomically variations. So sometimes you have a canal that's oval, ribbon shape or ovoid. It's not just the round that you're used to. You cannot just put the post here and fill everything else with cement and expect it to succeed. Okay, it doesn't work like that. So what you need to do is to do a custom fiber post. So you bring a fiber post and you basically reline it with composite. What you do there, you decrease the amount of cement thickness, so you have more composite. That means you more strength, higher bond, which increases the higher bond, and increased core strength. So this is called a custom fiber post. Just like you have a custom cast post and core, you have a custom fiber post, but you can do it chair side. The technique is simple. You just bring a fiber post, wipe it, bond it, wipe it with alcohol swab, dry it, then you bond it. You roll up a composite on top of it, lubricate the canal with saline or glycerin based, and you fill it, you press inside the canal, come out and cure. So basically you have the shape of the canal here in composite. So you have a custom fiber post with composite. This is entirely composite here. And so when you cement it, you have a very thin layer of cement, therefore you have a strong substructure, and you can build a core on top of it later. So this is an important technique. It takes you 1 minute. It just takes you 1 minute to do this, and it makes a big difference to the success of the tooth. So when you have an unfavorable design of the canal, please just don't put the post and just fill it with cement. Reline it with composite and make a custom fiber post. Increases the strength and the prognosis of that too significantly. Another technique you can use is the GC ever stick post. Honestly, I haven't used it, but it's the literature on it. It's beautiful, and what you do is it comes in packets like this. You remove it and you just fill the canal with multiple layers of these fibers, and then you cure it. You take it outside, then you cure it like this, and so you have a one homogeneous layer. So it's a great technique. I haven't used it honestly, but the literature on it is good. So hopefully we'll in the future we'll have time to use this one. It's called GC Ever Stick Post. The last thing we're going to talk about is coronal coverage, because the last thing you want is to have something like this, to have a tooth break in half. Actually, this happened. Patient had a large restoration, endo-treated tooth, and bam, and it's a 7. So remember what I said about the position of the tooth in the arch, the proper prosthetic design. This is an MO. We have 3 walls. There was no need for a post. But the problem was the coronal coverage was not done fast enough. So the problem was not with the core. The cuspal coverage or the coronal coverage was not done, and thus you have splitting mesial distally here, because you have excessive force. Remember, it's a 7, so I have a lot of forces. Remember the joint, the class 2 lever, it's in the back of the mouth. All the joint is there. The forces of the joint goes back to that tooth, and it's undertreated and structurally compromised. So you try, molars usually try to crown them as much as possible. In a review in 2007, it showed that teeth with crowns that are undertreated with crowns have a higher survival rate over a 10-year period than the non-crown teeth. The percentage was 81% for crowned and 63% for non-crown teeth. So it makes a big difference. And not every molar we crown. Like I said, depends on remaining tooth structure, the prosthetic plan, and the functional requirements. For example, this tooth, like I showed you before, it's only occlusal mesial. We did only a restoration, bonded restoration. I always like to say bonded because when you have a non-bonded, it's an issue. You're gonna fracture the tooth. But there was functional requirement was very minimal. It wasn't an abutment for an RPD. Patient was not Bruxer. The remaining tooth structure was well, so it survived. And I want you to look here. See how we did the functional requirement. See that? That's the amount of force you only have. See the articulating paper. So when you can get away with it, but if you do it properly, a proper a prosthetic occlusal design, this is what you need. So here we have little function there, just enough for that tooth. So it wasn't crowned and it survived. So you have to study the case. It's not just about, oh, I have enough tooth structure, or I don't have enough, I need to crown it. Like I said, it's more than that. In the summary, it's basically what I told you before. When you're restoring endodontic treated tooth, it's not just the tooth. You have to look at everything. It's a picture. You have to look at everything from frame to frame. The prosthetic plan, the position of the tooth in the arch, the requirements, the functional requirements of that tooth, and the remaining tooth structure. These are actually the 4 basics that you need to put in the back of your mind when you're restoring a tooth. The other things we talked about, I'm going to show you, which is the post length and the core material, the ferrule. These are all important, but they come second in importance to these. So the important thing is the prosthetic, position of the tooth, functional requirements, the amount of remaining tooth structure left. These dictate how you're going to restore endodontically treated tooth. Then you can go, like I said, to the type of core material, if you're going to use a post, the length and width of the post, and of course they need a ferrule. There's no talk about it. You need a ferrule. And the least important maybe is the type of post you're going to use. If everything else is intact here, the least important would be the type of post. And basically that's it. Thank you for hearing me out. And if you have any questions, yeah, I'll be happy to hear them.